This is Chapter 1, EMS Systems. I'm going to limit all videos to less than 15 minutes. So you will have 2 videos under Chapter 1, EMS Systems. This is our preparatory phase. Covers the first of 7 modules, and it prepares us for what we need to know to be an EMS responder. We're going to cover EMS systems, roles and responsibilities, probably for the most of this. Get into a little bit of quality improvement, research, and data collection. You need to know that this is a component of public health, keeping our community safe through EMS response. So an introduction, your emergency medical responder, EMR. The first medically trained person to either be on scene or to arrive on scene of an emergency. So your initial care may be followed up by what we call the continuum of care, people that will receive your patient after you've stabilized and may be transported. The EMS system, I want to emphasize the word system here. So it's not just 2 guys in an ambulance running out there. It's somebody reporting the incident, dispatching, dispatch, sending out the appropriate equipment as well as personnel, maybe a first responder or EMS response. That EMS response may be basic or advanced life support, and then transporting to the hospital. We'll integrate all of that with medical oversight, which is your medical director. So reporting, somebody sees, whether they witness or are part of the scene, calls 911. In the 254 counties in Texas, most have enhanced 911, which means when you call from a landline, a home phone, home-based phone, it comes up with the phone number and how many times that they've called 911 in the past and for what reason. Cell phones don't have that capability. We're having more technology now where soon 911 dispatchers will be able to get a text message and then send out that help. From dispatch, they'll send out appropriate personnel and equipment by pager, maybe by radio or telephone, computer, or other means. They're going to give them information as to what the call was about. And probably the 3 biggest pieces of information is the location, what the call was, what type of emergency, and that they'll have a callback number in case they need to get more information. First responders may be firefighters or law enforcement or EMS first responders that hold a certification. So we think of EMRs when we talk about holding a certification. First ones on scene to stabilize and report to the EMS responders what that incident is. I need you to hurry up. We've got a guy that's bleeding out. I can't control his bleeding, or everything is stable here. Then the responding units can kind of base their response on that. So an ambulance staffed by EMTs or paramedics is the second contact with the EMS system. And in Texas, you have to have at least 2 EMTs on the ambulance, but some areas will have waivers where EMRs, emergency medical responders, can operate as EMTs. So most of the time as emergency vehicle operators. Instead of saying ambulance drivers, we like to say emergency vehicle operators because it entails a whole lot more driving a 12,000-pound gross vehicle weight ambulance than it does your own personal vehicle. Having that equipped and stocked vehicle that makes up a BLS response unit or ALS. And the biggest way to remember the difference between these 2 is any of your care, any of your treatment going to go inside that person? With the exception of a defibrillator, which sends electricity through that victim's heart muscle, at the BLS level, we don't do anything invasive. You may put air into their lungs to breathe for them, but that's a natural thing that we would normally do on our own. So we think of ALS as putting pain medications into their vein, or fluids into the vein, or a tube down their throat for them to breathe. We think of advanced life support as being advanced EMTs and paramedics, but all of those advanced personnel still do the same skills that EMRs do: airway maintenance, bleeding control, prevention of shock. So BLS is just as vital to a patient as advanced life support. National Registry supports 4 levels of certification: the EMR, the emergency medical technician, the advanced EMT, and the paramedic. And again, AEMT and paramedic are advanced life support. EMR and EMT are basic life support. In the state of Texas, in all places, you have to have medical direction to function at the advanced level, advanced life support level. Therefore, if I'm driving down the highway out of my jurisdiction where I would have medical direction, off duty, and a motor vehicle crash occurs, I would function at the EMR level. I would not have medical direction to be able to start an IV, even if I carried those supplies with me, unless I could call for medical direction and have that given to me. So EMR, that BLS, is a very vital part of that first response link. In Texas, those translate to from EMR to ECA, Emergency Care Attendant, so that's the patch that you'll be wearing when you obtain Texas certification. EMT Intermediate, and Paramedic. There's also a licensed paramedic, which means that person completed an associate's degree in EMS or a bachelor's or higher degree in anything, and then they can apply for a licensed paramedic. Hospital care is that last of the EMS systems. Where you're going to take that patient to, and it needs to be appropriate, not necessarily the closest hospital. So appropriate may mean that you take a patient bypassing in closest hospital. Maybe it's a very small hospital, to go to a trauma center or a stroke center or something that's appropriate for the definitive care of that patient. It may be by ground ambulance, or it may be by air ambulance. And in air ambulance in rural areas, we mainly think of helicopters. We have to look at weather conditions, can they fly, to make that determination of which is better for the patient. We are under public health, so we think of community health with EMS. And that last one, preventing the incident of progression of diseases, that's where we fall. But we also have to think about education and screening programs that we can be involved in that prevent those accidents from happening. The texting and driving is such a problem now. Going into the schools and giving them, real case situations to deter that, then maybe you prevent that injury from occurring. Little deal on history of EMS. Before really the 1970s, most of the time people that were injured were transported by funeral homes. They were the only ones with a vehicle that had a stretcher that could transport people in the laying down position. But the responders didn't have any real training for that. Just pick them up, bring them in. And we found in the military sector that, especially during the Korean conflict, that we found that patients that were moved from the field to definitive care very quickly had the best outcomes. And still civilian sector lagged behind that. So in 1966, the Accidental Death and Disability paper was published. It was called The Neglected Disease of Modern Society, which was trauma. They nicknamed it the White Paper. And this fell under the Department of Transportation because at that time, most of our trauma occurred on our highways, 70 miles an hour before we actually had that little gas shortage period where the speed limit dropped to 55. And people would roll their vehicles and all, and there wasn't really a system to go out there and take care of them and transport them. Fire and police would show up, and then here comes a funeral home vehicle to transport, but very little care for those victims and not good outcomes. And so in the 80s, we started having more and more EMT classes, and then the evolution of advanced life support to paramedic became pretty common. So today all EMS providers go through a standardized course. There's a national certification as well as state certification that makes sure that there's at least a minimum standard that's being met. 10 standard components of the EMS system. And it's not just two guys hopping out of the ambulance, running in their uniforms doing stuff. We're regulated by the Department of State Health Services in Texas. We have policies mandated by our EMS provider as well as our medical director. We have resource management for the fleet, the equipment, the training, almost everything. Human resources, whether or not you're paid, there may be non-paid benefits that are factored in. Initial and continuing education training, transportation equipment, meaning that they're properly maintained. You don't ever want to have a breakdown in an ambulance or run out of fuel. Medical and support facilities, good communication with our receiving facilities or neighboring EMSs, a good communication system, knowing that there's going to be dead zones that you will find yourself in, and having ways around those. With satellite phones, it's almost unheard of in these very remote areas not to have good communication, but that all comes at a cost. Public information and education, you want to do everything you can to keep your community informed on why you're needed. We'll talk a little bit more about the medical director, but that physician oversight of your whole system. Trauma systems and development within our area. We are served by Southwest Texas Regional Advisory Council. We call it STRAC, out of San Antonio. So if you have a disaster response or something and they overwhelm, all the needs of your community are overwhelmed by what you can supply, you have a number, you have a phone number you can call, but you have a resource there that can bring in other help. And all this is for evaluation. What we're doing now, is it good? Is it bad? What can we fix? What can we do to make it better? Little word about transportation. We think of emergency vehicles as going fast, running through red lights, against traffic, disobeying the posted speed limits, those kind of things. But we really want to think about a prompt transport, which means that we look at the patient's condition. Do they need for us to run lights and sirens? And if they do, with that rapid transport, we still have to do it within a safe manner. We want to make sure that everybody gets there safe, everybody goes home. We don't jeopardize the safety for what we think is a life-threatening problem. EMR training, these are the skills at the foundation for basic life support. So it doesn't matter if it's a physician that arrives on scene without any tools, they're going to do the same thing that you're taught to do in this class. Initial, basic life support, stabilization. So I think that's kind of a cool thing that we all share that. The skills that you'll learn are divided into two main groups. For trauma patients and for medical patients. So we're going to talk about all of these things. You'll do skills to help stabilize patients with any of those. Your goals are to evaluate, do patient assessments, stabilize, and with a minimum amount of equipment. You're going to have to learn to improvise, and you have to just justify everything that you do. For instance, if somebody's out hiking and you think they've broken their ankle, if you decide to splint it with a stick because you don't have anything versus waiting for the ambulance to show up, you just have to justify why you did what you did. Otherwise, you help paramedics as they arrive on scene. A big thing of EMR training is learning what we should not do. So we all share this common thing with our patients, is to first do no more harm. If we don't have proper equipment to move them, we don't move them unless the scene becomes unsafe. And being non-judgmental. We're going to take care of all of our patients, no matter their, how we feel about their lifestyle, or are they smelly, or can they pay their bill. We're going to treat all patients the same. This is a good point in here to stop the first part of this, and then we'll continue on with the part 2 of chapter 1.